All right, it is 8 o'clock by my trusty computer here, so we'll just give it a couple minutes. Glad to see everybody joining us this morning. We'll be starting shortly. Welcome to everybody who's just joining the webinar. We'll be starting very shortly. All right, let's dive in. I want to be respectful of everybody's time because I know we've got a lot to pack in this morning. Good morning and welcome to Eggheads. My name is Christy Ariano. I am Managing Director of Marketing and Communications for the Colorado Health Institute, and I'm just so delighted that you've all taken time out of your morning to join us. Before we start, I want to let you know this session is being recorded and we will have time for questions at the end of the session. CHI believes that good health policy leads to a healthier Colorado. Every day we bring research, insight, and expertise to leaders across the state because informed decisions lead to better health for all. We're an independent nonprofit organization. We do work for the public benefit that is funded by generous philanthropic supporters. We also consult with organizations including community groups, hospitals, payers, government agencies, and foundations to provide not just analysis and data, but strategic planning, facilitation, complex modeling, evaluation, and strategic communication. The work we're sharing today is the result of one of those partnerships. This is a partnership with the Office of Behavioral Health. Before we dive in, I also want to extend my gratitude for joining us on what I know is an early hour and also is the first week of school. And I think a lot of people are trying to remember how to juggle morning routines and the workday, and it's hard to get going. So I thank you all for joining us. And now that back to school is part of the routine again, I'm just sort of curious. Love to hear from those who are joining us this morning. You can drop your responses in the chat, but tell me about the best part of your summer, or if you were able to take a vacation, where did you go? Go ahead and drop that in the chat. I know sometimes the chat does default to panelists only, so make sure you are sharing with the group. All right, either we have a quiet group or my chats are not just, now they're coming in. Hiking in Rocky Mountain National Park. Oh, finding out that my wife and I were pregnant. I love this. This is already making me my morning. Paragliding in Glenwood Springs. I'm seeing a lot of taking advantage of Colorado, Hawaii. Oh, I could just do this all morning, but I thank you everybody for joining, and I am loving this. So, and it's good to hear that people were able to take a little break, enjoy the sunshine, enjoy the summer. Really appreciate that. Eggheads started during the pandemic as our way of making these connections, as staying connected with the healthcare policy community. And it's really become a bright light for us because we're able to connect, find out what's going on in your world, and engage in conversation about what's happening in health policy. And I'm so excited about today's presentation because it really is a bright light in the state. It's a program that's truly making a difference. So to set the stage for this work, I'd like to introduce Jenny Wood. Jenny is Director of Criminal Justice Services for the Colorado Office of Behavioral Health.
Good morning, everyone. As previously stated, I'm Jenny Wood, and I'm just here to welcome you all to the presentation today and just give you a little history and background on the co-responder programming in Colorado. So around 2014, 2016, smaller programs started popping up throughout the state, but it was nothing formal like you see today, not a larger movement. And there were little piecemeals, I would say, of funding put together from our office for those programs. And then if you fast forward to 2017, the legislature really recognized the need to create better partnerships between law enforcement and behavioral health, because law enforcement are typically the first point of contact when someone's in a behavioral health crisis. So it really makes sense. And in 2017, the Strengthening Colorado's Crisis System bill was passed, and 8 co-responder programs were funded out of that. And those programs began in 2018, because as you know, with state funding, it takes time to get contracts underway. 2019, we expanded to 4 more programs with the Senate Bill 19008. And it just shows that co-responder really is a priority in our state. And we were able to use some of our SAMHSA, which stands for Substance Abuse Mental Health Services Administration. We love acronyms in state government and forget not everyone knows them. So SAMHSA funding is federal funding. So we were able to use some of our block grant, which is a set dollar amount that goes out to all the states, and it's population based, to fund some more co-responder programs. And then 2019, maybe 2020, other state agencies started popping up with funding co-responder programs. So we really come together with those agencies to make sure that we're sending the same messages and on the same page and aligning our efforts. And just this year, in 2021, I don't know if anyone else has a hard time with the years since the pandemic and being at home for so long, there was more co-responder funding that came through DOLA. And why do we do this? Why do we fund co-responder programs? It just makes sense, like I said earlier, for law enforcement and individuals, families, and the communities that we serve, because they are the first point of contact, and really pairing them with mental health clinician helps facilitate that work. And we also know that 35% of individuals in Colorado that are involved in the criminal justice system have mental health needs, and those are the ones that have been identified. And 74% in the criminal justice system also have substance use needs. So it just shows that there's a high percentage of individuals presenting with behavioral health needs in the criminal justice system with primarily low-level nonviolent offenses. So why not reduce the number of people entering the criminal justice system and divert them to where they can actually get the services they need? And we also know that our incarceration really isn't the place for someone who has a nonviolent offense and who has a behavioral health need that they need treatment for. So really connecting individuals to treatment rather than incarcerating, it's just more humane, and it makes sense for everyone in the long run. And that's all I have. I'm going to hand it over to our presenters so they can really take you into the inner workings of our program. So welcome, and thank you for taking your time this morning.
Thank you, Jenny, and thank you, Christy, for those introductions. Good morning, everyone. My name's Jalen Ingalls, and I'm a policy analyst at the Colorado Health Institute. I lead a lot of our behavioral health work here, including the co-responder evaluation for about the past 3 years. You'll see I'm joined by a few of my colleagues who have worked with me on this project. Lindsay Whittington is a policy analyst at CHI as well. She works on quantitative research analysis of public health systems and creates data visualizations for our team. I'm also joined by 2 colleagues from the Office of Behavioral Health. Emily Richardson is the manager of co-responder services and is a licensed clinical social worker in the state of Colorado. And Katie Tenholzen is the senior evaluator for criminal justice programs at OBH and has evaluated multiple state programs, including co-responder. The team of 4 of us presenting you today are not the only people who've touched this project. We've been supported by many people at OBH, including Jenny Wood, who you've just heard from, and others there, as well as others on the CHI team. It really truly was a team effort, but the 4 of us are here today to share the results with you of our recent evaluation and answer questions you have about the program. So during our time together today, we're going to give you an overview of Colorado's co-responder programs. We're going to review the findings from our evaluation efforts and share a little bit about the limitations and opportunities to improve evaluation moving forward. Over the past years, this program has grown not only in size, but in how they operate, the partnerships they have with each other and within their communities, and in their impact. Our evaluation efforts have adapted as the program has, and this presentation will detail some of the progression and change the evaluation team has made to stay aligned with the work of the program and evaluate a multi-county program that's working daily to improve behavioral health outcomes. I'm going to pass it to Emily, who's going to share a bit more about the programs now.
Good morning, everybody. So I'm going to give you all just a little bit of context and do a little bit of level setting on what co-responders are and what these programs do before we really dive into the evaluation itself. So as Jenny had mentioned, law enforcement has by and large been responsible for responding out to behavioral health calls for service because we've all been trained from, childhood to call 911 if we have an issue, and behavioral health is no exception to that. And so over the years, we have had more and more funding provided and more coverage throughout the state for these programs. Simply put, these programs are teams that pair law enforcement and behavioral health specialists together to respond to crises and other police calls for service in the community that that have a behavioral health nexus. And so the goals of these programs are, the four main goals are to prevent any unnecessary incarceration or hospitalization. We want to keep folks in the community as much as possible. And if they don't need to be in jail or in the hospital, we don't want them to end up there. We provide alternative care in the least restrictive environment through a coordinated system-wide approach. While these programs do focus on individuals in the community, it is really a system-wide approach, a lot of collaboration and coordination within the community and within stakeholders. We want to prevent duplication of behavioral health services, and we also want to facilitate law enforcement back to their patrol activities. We want behavioral health clinicians doing what they are trained to do and what they do best, and we want law enforcement back to what they are trained to do and what they do best. And so these programs also really, like I said, strive to improve cross-system collaborations and relationships, coordination, and there is also quite a bit of formal and informal cross-training between the systems as well. And so given the diverse makeup of Colorado and Colorado communities, these programs have some flexibility in how they're structured. We want programs to have the space and the flexibility that they need to meet the unique needs of their own community, and to take into consideration the various things like population density, call volume, and local department and agency resources that they have available. And so taking all of those things into consideration, there are a few different models or team configurations that we have throughout the state. We have primary response, which is seen by and large in more densely populated areas. So having a dedicated team model with dedicated law enforcement and dedicated behavioral health clinicians or personnel who respond out together in tandem at the same time. Or we do have some programs who also have a dedicated clinician that responds alongside an officer, but not necessarily as part of the officer isn't necessarily dedicated to the team. We also have secondary response, which by and large is seen in more areas with lower population density or with departments who have lower call volume for behavioral health related calls, or who don't necessarily have the resources at the moment to provide a dedicated officer or multiple officers to the team. And the secondary response models, the behavioral health clinician generally responds to the scene when they're requested by an officer, and it's generally after the officer has already secured the scene and ensured everything is safe. And we also do have a few kind of, I like to call them hybrid models, where it's a little mix of primary and secondary response. A clinician may spend some time riding with officers and responding out during high call volume times, and they may respond out on a secondary basis and do follow-up during the lower volume times. And then these programs, all of them generally do some post-call follow-up, as well as receive referrals for outreach during times when they aren't on duty. And there are also a growing number of programs that have a dedicated case manager or peer specialist that also provide follow-up, linkage, and other resource acquisition services. There are also a few programs that have a dedicated EMT or a paramedic on the team. So 3 people are responding out to every call. So now that you have kind of an overview of what a co-responder program is and the different configurations, let's take a quick look at the funding that we have available and where these programs are. So as Jenny mentioned, we have funding from different agencies within the state, as well as some programs in the state utilize local, state, or federal funding. So we are just talking about OBH funded programs. OBH has around $7.5 million total in funding from a few different funding streams, including general fund and marijuana tax cash fund. And this map on the screen highlights the counties that we have programs in. There are quite a few programs, quite a few agencies, as you can see from the numbers on the screen. So this is kind of the cleanest way to illustrate where programs are. Not all of the programs are county-wide necessarily, but if you start getting into the metro area, we would have it'd be a very busy map if we tried to show each and every location. So we're in 23 different counties. There are 26 total programs, and at last count, 35 teams. So some programs have multiple teams, kind of the program is sort of the umbrella, and there are multiple teams within it. When there are multiple law enforcement agencies who have dedicated programs within their agency. And then some programs cover a number of different law enforcement agencies or even a couple of counties. So that is why we've got so many different numbers on this slide. But we've got quite a good reach, and I think in Colorado, at least, co-responder program is only growing. So now that we have some context and understanding of what these programs are, we are going to dive into a discussion about the evaluation itself.
Great, thanks, Emily. So like I mentioned earlier, over the past 3 years, our evaluation has taken different approaches to assess the co-responder programs that it has adapted to the evolving nature of the program. And as you just heard from Emily, we've got different approaches to implementing the model, such as secondary, primary models that are used. And we have different counties, different cities, locales, and when you're evaluating those, can get tricky. And so we've had to adapt and adjust and learn from all different programs across the state. So when we started the evaluation, we started by speaking directly to those who implemented the program. We created a survey to distribute to co-responders and law enforcement officers to ask about implementation barriers and successes, as well as ask them to do a qualitative assessment of the program impact thus far. The results suggest that while co-responder teams felt that they were successfully implementing the program, a commonly identified barrier was developing the policies, procedures, and partnerships between law enforcement and the behavioral health providers who are co-responders. That partnership needed some development and needed to work together to kind of figure out how they work in the field, how they collect data, and really streamline that within each department. The results of the survey are detailed in an interim report that was published in June 2020, but we've just published a new report that I want to make sure we drop a link for you in the chat. So if someone from the team can do that, that would be great. We just published an updated evaluation. So some of our interim work was really qualitative, and we shifted to a more quantitative approach that's detailed in this report. So we also conducted key informant interviews and focus groups and learned about data sharing challenges and team challenges that I just described. While everyone seemed genuinely interested in making the partnership work, There are challenges operationalizing it, such as creating procedures that both the behavioral health providers and that law enforcement were comfortable and able to follow. That was a key theme that we heard early on during implementation, but that has seemed to been worked out in many cases, and some policies and procedures shared to make that a smoother partnership. Finally, on the quantitative side, we started with a tool that collected aggregate data. For example, each site would report on the total number of people seen each month, the demographics, and how many of those had a specific outcome, such as being taken to a hospital or arrested after contact with the co-responder team. And that report again was each program giving us the total aggregate number every month. But we quickly realized that while those gave us good information about the reach, we couldn't break down to understand what each client's outcomes were, how many times each client was contacted by the program, and other information that we wanted to learn. So we had to adapt in order to be able to answer the evaluation questions we had proposed. We developed a tool to collect individual level information, which means for each person served, we collected demographic information, details about the type of response, and details about the outcomes that that person had. This was a huge pivot and, quite frankly, a larger data ask of the sites. So we piloted it with 4 sites to test this tool. We called these the pilot sites, real creative, who helped us tweak the tool as we went and make sure it was effectively and accurately collecting the data we needed. Once we finalized this tool, we asked all sites to switch over to using this new product. So pilot sites collected data with this individual level tool starting in September 2019, followed by all sites shifting over in July of 2020. The results presented today and in the report that we just published, which there should be a link to that report in the chat, includes an analysis of the pilot sites for that year of data that we have from September 2019 to September 2020, as well as results from all sites from that 3-month period, July of 2020 to September of 2020. So you'll see in that report that we reference pilot sites and all sites. That's what we're referring to. And in our data that we share with you today in this presentation, if you hear the word pilot site or all sites, that's the transition that we're talking about that really gave us the data we needed to look at things like high utilizers, people who see, who are coming in contact with the co-responder multiple times, things like that, that we weren't able to do previously. All right. So next, we're going to walk through the 5 main research questions that we proposed as a part of this evaluation and provide an overview of our answers to those questions, including limitations and challenges associated with that. We won't be able to cover everything that we found in this presentation, so we're going to give you a high-level response and how we evaluated or answered each question, but you'll find a lot of details and additional analyses in the report. So after we're done, I encourage you to check that out. I'm going to pass it to Katie, who's going to introduce our first research question.
Thanks, Jalen. Our first research question involves the reach of the co-responder programs into their respective communities. We saw that there was a comment in the chat specifically asking about what we mean by communities. Great question. That's kind of a general term we use to refer to jurisdictions, whether that be, because these programs are so varied, like Emily mentioned, some programs involve police departments, which are for a certain city's jurisdiction or potentially multiple cities in rural areas. Others are whole county jurisdictions. So when we use the term communities, we mean the reach of that specific program wherever their community is, whether that's a certain section of the Denver metro area or an entire county. So we do use that pretty generally. For this first research question, we wanted to know how well co-responder teams were meeting the existing need to respond to 911 behavioral health crises.
So the evaluation actually found that the co-responder program was able to reach many Coloradans within each of the program's local communities. And just between that July and September of 2020 time period across all sites, the co-responder program actually reached over 3,000 unique individuals, which is really exciting. And many of these individuals ended up being served by the program more than once a month, which we called high utilizers. And across the 3-month study period, 1/3 of all responses involved one of these high utilizers. And there were fluctuations from month to month on how many of these individuals came into contact with co-responders and the program itself.
An ongoing challenge was identifying the level of need in the community. Most 911 dispatch centers don't currently have an easy way to identify a call as a behavioral health call. So we're working with co-responder programs and law enforcement agencies to identify the least burdensome way to track this information. When we're able to see the actual amount of need in the community, then we'll be able to more accurately measure how much of that need is being met by the co-responder programs. Our second research question involves the reduction of formal actions by law enforcement. As many of you are aware, a call for law enforcement may end one of several ways. The call may be resolved on scene with no further action. The person may be taken into custody under arrest, or the person may be placed under one of several types of involuntary hold, such as an M1, an M.5 for transportation, or emergency commitment for drug and alcohol, and transported to a crisis center, withdrawal management clinic, or emergency department. These are all considered types of formal action.
So during the 3-month study period, we found that about 1/5 of contacts made by co-responders resulted in an involuntary transport of that individual. And most of these involuntary transports were actually the 72-hour mental health holds. So using data over a year's worth of time from those 4 specific pilot sites, we were able to track these involuntary transports over time. And what we found was that the percentage of contacts made by co-responders that resulted in these 72-hour mental health holds actually decreased during that time period.
For each call, we ask law enforcement to use their best judgment to report whether the call may have ended in some type of formal action, such as arrest or involuntary hold, and if that formal action was avoided by having a co-responder present. We recognize that this is an imperfect measure because even very experienced officers cannot predict what would have happened in a given situation with total accuracy. Therefore, we rely more on what actually took place at the end of the call, so we gather both of those pieces of information. Our third research question involves co-responder programs connecting individuals to needed behavioral health services in the community. Typically, this would take place through referral to services at the end of a call for service or during a follow-up contact with the individual.
So the evaluation found that co-responders were able to assist with the enrollment of individuals contacted by the program into needed behavioral health services. So overall, across all the sites during the 3-month period, about 30% of contacts made by co-responders resulted in a new enrollment of that individual in a behavioral health treatment. So when we track these data over time using the pilot site data, for that entire year, calls resulting in a behavioral health enrollment increased from about 25% to 36% between September of 2019 and September of 2020. So because the co-responder program is now capturing individual level data, we can say more about outcomes and how they may differ across certain groups served by the co-responder programs. So one example of this is here on your screen. We can see here that we analyze the differences in behavioral health enrollment rates by race group.
The biggest challenge in gathering information about whether individuals were enrolled in behavioral health services after the contact with co-responders is that the information is self-report. So the co-responder is asking the individual, are you enrolled in behavioral health services most of the time? The co-responder can't always confirm that information. Some programs have been successful in gathering this information because their own agency provides services to that individual. Others contract with a case management physician, and that case manager is able to communicate with the co-responder team. And a co-responder may be able to set the individual up with an appointment for behavioral health services, like outpatient treatment, if that's what's appropriate at the end of the call, but they can't ensure that the individual actually attended the appointment. So all programs provide some level of follow-up outreach to individuals, but this remains a challenging data element to collect. Our fourth research question involves the overarching program goal to allow behavioral health professionals, like Emily said earlier, to address behavioral health issues and allow law enforcement to return to patrol activities. Measuring the length of time an officer spent on a call compared to the length of time a co-responder clinician or a co-responder case manager spent on the call allows us to take a closer look. Quick note, this difference in time spent will not be apparent in programs with that primary response model where the dedicated co-responder officers respond to a call directly with their clinician partner.
All right, and as you can see here, co-responders did reduce the amount of time law enforcement spent on calls. 1 of every 3 calls reported reducing the amount of time law enforcement spent, allowing them to return to their patrol duties. In this graph, the blue line represents calls where law enforcement spent 0 to 30 minutes at the scene, yellow is 30 to 90 minutes, and green is 90 minutes and more. As you can see, over time, the yellow and green lines representing longer law enforcement time on calls decreased, whereas the blue line increased. This suggests that over time, co-responders were able to more effectively address on-scene situations and get law enforcement back to patrol.
A complicating factor about looking at the length of time each individual spends on the call is that there are often others dispatched to the scene as well, other law enforcement officers, fire personnel, paramedics. It would be ideal to collect the amount of time spent by those additional people as well to really see a more complete picture of the impact of the co-responder on the scene. But that would create additional reporting burden on the program staff, and we try to keep that as low as possible. As a compromise, we included a yes, no, or not applicable option in the reporting tool that allows the program to report co-responder facilitated return of law enforcement to service or co-responder facilitated return of fire or EMS to service. An additional factor to consider is safety on the scene. In some situations, it's unsafe for a co-responder clinician to arrive on scene before law enforcement has assured that the area is safe, like was mentioned before, because this could cause, and as a result, this could cause additional discrepancy between the amount of time law enforcement and co-responders spent on the scene. Our 5th and final research question centered on cost. We and our leadership wanted to know if the co-responder program was shown to be cost effective, specifically which costs were avoided with the diversion of arrest or emergency department visits.
All right. So before I jump into the findings quickly, we've established that the co-responder program reached people with behavioral health needs and were able to effectively connect people to behavioral health services in their communities. But the next question that everyone wants to know, including us as evaluators, is what costs were avoided by connecting people with behavioral health services as opposed to a law enforcement response. We recognize that this is incredibly important for understanding impact, and reasonably so why OBH is interested in this. And I'm also here to tell you that it's incredibly difficult to get that dollar amount. So we know from the data that co-responders were able to divert people from formal actions, including emergency department and jails, and that the individual level data, we know how many. For example, 169 people were diverted from emergency departments in a 3-month period. The challenging part is to identify which costs were avoided by diverting people from these formal actions. It's tricky because each person's circumstances would be different in a hospital or a jail setting. It depends on the location of the facility, for example, costs in rural versus urban counties. And the daily costs for emergency room visits and jail stays are very hard to calculate and just vary across the state. So we were able to use a couple of sources, such as the National Inpatient Survey, to get an estimate of the cost of an emergency room stay. And we estimate that up to $1.5 million were avoided by diverting people from emergency room visits. And with jails, which depends on the county again, we estimate that diversions from jail avoided anywhere from $840 to about $10,000 in costs. These data on costs come from a 2017 memo by the Colorado Legislative Council staff that shows the distribution of a daily cost for staying in jail from different counties, and that varies. And that's why you see such a large range from $840 to $10,000, because we're accounting for different counties and the cost that they have to operate their jail on a daily basis for the number of people there. So while these are wide estimates, we wanted to at least give you a hint of what this might look like. We know, again, it's tricky to calculate and that these numbers are big and broad and hard to make a specific dollar amount ring true for this program, particularly because of the assumptions we had to make and some of the challenges. So I'm going to turn over to Katie, who's going to share a little bit more about some of the reasons why this is complicated to calculate.
Thanks, Jalen. There are so many ways that cost data can be analyzed, and it's also difficult to gather specific cost information that resides within a private system like healthcare. Like Jalen mentioned, we also recognize that locations across Colorado, whether urban or rural, may have widely varying average costs for services. Additional costs that could be included in future evaluations are avoided transportation cost when a call is resolved on scene, and avoided cost for times when EMS, fire, and other law enforcement officers were able to return to their duties while a co-responder team stays on scene with an individual. So considering those additional pieces could allow for a more complete picture of what costs were avoided by the co-responder program. Those data pieces can be difficult to track down. Speaking of lessons learned and future evaluation, now we'll discuss some lessons we learned over the course of this evaluation that could inform future evaluations of the co-responder program.
Emily's on point next. Emily, are you able to unmute?
That's right. Okay. Sorry. There was a delay in response with my computer, so my apologies. So one of the lessons learned, it was kind of more of a reinforcement of what we thought we knew from the interim report, was the importance of having strong implementation, including collaborations and really fostering those relationships between partners and stakeholders. It also highlighted opportunities for improvements in standardization of practices and the need for development of best practices for these types of programs.
Like we've mentioned in previous slides. Oh, were you done, Emily?
Yes.
Like we've mentioned in previous slides, it's difficult to compile data from multiple sources, whether that includes dispatch information, police department call logs, or case management electronic health records. With additional time and ideally systems that were able to speak to one another at some point in the future, maybe, we could ensure that nothing falls through the cracks or gets miscoded when we combine those data from different sources.
Okay. The next lesson learned was the next limitation and lesson learned is that these programs really don't fit neatly into any kind of one box, so to speak. They have kind of a mix of duties and roles in the community. So they are part crisis response, part criminal justice diversion. And as the slide says, they are not a monolith, which can create some difficulties when trying to define what a co-responder program does and how it's different to similar programs such as mobile crisis. Also, having too narrow of a focus or a definition of what they do, that they're completely crisis response or completely criminal justice diversion, can lead to neglecting some of the aspects that make co-responder unique, such as some of the shifts in culture change within behavioral health and law enforcement that happen organically with these programs, as well as a focus on harm reduction and trying to meet clients and community members where they are. So while the ultimate goal is to get somebody into treatment, that may take some time, and there may be some issues present that need to be addressed before engagement and services can really happen. And then the next one, which Katie actually touched on already a little bit, is defining what a behavioral health call is. This isn't something that has been common practice within law enforcement agencies to identify just behavioral health calls for service. Dispatchers and call takers in dispatch centers have very little time to identify what the nature of the call is. So it may come in as one thing, and when officers or teams respond, it's very clearly something else. But understanding what the total number of behavioral health calls for service are for a police department or sheriff's office is really important in understanding the community need and whether or not a program is meeting that need, and can also provide some really beneficial operational information for programs. And it's also really critical because we can't have a comparative control group really without this and similar in demographics. So if we want to compare one county or one agency who has co-responder to another that doesn't, we need to make sure that we're able to identify that control group.
Like Emily mentioned, it's difficult to define a behavioral health call, and because of this, it wasn't feasible to use a control group in this evaluation. There weren't denominators to compare to operating co-responder programs. So future evaluations could partner with one or several jurisdictions that don't currently have a co-responder program. If a method of tracking behavioral health calls could be defined and used in those jurisdictions, then their call outcomes could be compared to existing co-responder program outcomes in similar jurisdictions. Let's turn it over for question and answer.
Yeah, thanks, Katie. So we're happy to answer any questions you have about the program or our evaluation efforts. Please use the Q&A function to ask those questions, and we'll respond to as many as we can with the time we have left. While you're getting those questions typed in, I just want to reiterate that there's a lot of great findings and additional findings in the report. We weren't able to talk about all of them today, but we hope that sharing some of the challenges and the things that we've wrestled with and thought through and how the evaluation has progressed will help those of you who are thinking about evaluating co-responder programs or other programs that are similar to this in your communities. And for those of you who are looking for specific results, you understand some of the things that we've considered and where there are some gaps in the evaluation, but also some opportunities to move forward with learning more about the co-responders as they've grown and as we think about our evaluation growing in alignment with these programs. So please drop your questions in the Q&A. We're going to jump right there. I'm going to stop sharing my slides in just a minute. So I want to make sure that you have our contact information. We're going to ask that you direct any additional questions or follow up after this presentation to Emily Richardson at the Office of Behavioral Health. Her email is on the slide. She will be the person funneling questions as they come in so that we're not all getting different questions or maybe the same questions. So please write that down if you're interested in learning more. She will be your point of contact. So I'm going to stop sharing my slides and jump to our first question. Emily, I know that we missed a question early on about your slide, slide number 5 about the communities. Someone asked if we could define how we are defining communities as far as the different counties and cities that are a part of this program. So Emily, if you can come off mute and answer that question as our first question, that would be great. It looks like Emily's frozen. Katie, I'm wondering if we can pass this question to you.
Let's see. I'm sorry, I was focused on the additional questions coming in. Which one were we going to address?
Yeah.
Emily, are you back now?
I think so, maybe.
Maybe if you turn off your camera, there, we're hearing you better now. And now you're on mute.
All right. I think the question, I'll see if I can take a stab at it. And it sounds like maybe Emily answered it in the chat function already, and I missed that. The question was about how we're defining communities as far as the city the county, the different programs. Emily, I think you've already addressed that, but
Sorry about that. I addressed that when I was talking about my first research question. So we got to that one already.
Perfect. All right. Our next question is, how many of the frequent flyers or high utilizers actually received treatment? Any data on that? Katie and Lindsay, I'll ask both of you to respond. Lindsay, let's start with you, and Katie, if you want to fill in any additional details.
Yeah, that's a great question. So we had a really interesting analysis where we actually tracked these high utilizers over time to see if they were at any point enrolled in behavioral health services. And what we found was that the more that these individuals come into contact with co-responders, the higher the likelihood is that they get enrolled in services, which makes sense. So it's basically, you know, we're finding that these programs are really a really integral point of contact to really get people to the needed behavioral health services that they have in their communities. So that's a great question. And we definitely are interested in knowing more about this specific kind of population that are served by the programs.
Yes, just to tag on to what Lindsay said, we continue to monitor that at OBH with the monthly data that comes in. We have received all of the data for fiscal year 21 and are looking at putting together a publication that gives some of those kind of quick facts of results, and high utilizers will definitely be included in that.
Great. And Katie, that actually gets to another question of when will the data for a larger time frame be released? It looks like the report is July to September 2020. We are collecting those data on an ongoing basis. So Katie, do you want to respond to or share a little more about what you said as far as next steps?
Yes, this is in the works. Emily and I have been discussing what it looks like just because this program is so new. And typically at OBH, we really prioritize the statutorily required legislative reports, and there is not one required for this particular program at this time. So it's really up to OBH to kind of ask the community, what do you want to know about this program, and communicate with our communications department to disseminate those results regularly. Like I said, we are currently working on a fiscal year 21 report, which will cover July 2020 through June 2021.
Thanks, Katie. And another interesting question about comparing our findings to any co-responder programs happening outside of Colorado, and how these results, or do we know if these results are average or better? So I'll answer the first half of that, and then Katie or Lindsay, I'll let you answer the second half. We've looked at what other states are doing in their evaluation efforts, particularly early on in ours. And because these programs are so new across the country, the evaluation methodology is evolving. And as you saw, every program is implemented differently. And so making these comparisons is incredibly challenging. We think that the field is growing as far as how these programs are being evaluated. But at the moment, we don't have any sort of comparative state or findings to say, you know, to crosswalk our results in Colorado to those in other states. And the second half of your question, Julia, was, do we know if these results are average or better? Which is a really interesting question that I'd like to share a little more, even within comparing Colorado's program. So Katie, do you want to take a first stab at answering that? And then Lindsay, if there's anything you'd add, jump in.
The quick answer is that we don't know currently, for a lot of the reasons that Jalen mentioned. It's really difficult to look at, to compare programs as apples to apples because program types can be so different and models can be so different. Emily can maybe speak to how some programs kind of co-opt more of a crisis response model. And even in Colorado, we have some programs where law enforcement is not involved and folks are responding, behavioral health clinicians are responding. So specifically with programs where law enforcement is involved, there is also a large difference between types of jurisdictions being served, types of outcome measures being measured. And my quick answer is that I don't typically have the capacity to do this work, which is why we contract with great providers like CHI.
Thanks, Katie. Lindsay, anything you'd add to that as far as comparing or understanding what are good results?
Yeah, that's a hard question. Yeah, because I feel like too, like caseload, just the makeup of the teams, like there are so many different factors when trying to understand like what is kind of like the baseline across all these. But that's what I think like at least tracking amongst the programs themselves over time at least gives us an idea of like how are they doing when they started, when they had kind of these implementation barriers and they're trying to get their programs off the ground and they're trying to figure out how these different kind of behavioral health and law enforcement come together. And then as they start to really, get going in their program, how do they increase or how do they kind of serve more people or, what does that look like over time? I think that's kind of the way I'm looking at it right now, or at least one way we can kind of track that to see how they're serving individuals that need help in their communities.
Something. All right. Our next question is about data collected about the costs of implementing co-responder programs. Thinking about staffing, infrastructure, outreach, all of those things have costs, and just developing those partnerships. And so the question is, what data was collected and how have those been addressed in communities? And are those costs reported anywhere? I'm going to let Emily answer that if she's able to come off mute. And if not, Katie, I'll turn to you as maybe to what you see on the back end at OBH. But Emily, are you able to answer that question?
Hopefully.
We can
you
hear
hear me okay? Oh,
yes.
Perfect. Yeah, I think that is a difficult one to answer, mainly because, so at OBH, we do have, programs, complete budgets, and it's a fairly detailed budget. So we do have the information as far as what programs are utilizing our funding for. Where it gets difficult is when there are multiple funding streams on board. So if one program has some federal grant money, some state funding, some local funding kind of mixed in, OBH doesn't require programs to submit all of their financial information. The other tricky piece of that is that, we basically said to programs, here's the amount of money that we can offer. And so oftentimes they make it work within that amount of money. So there may be some things that a program would love to have, but they aren't necessarily able to afford it, or that would be helpful, but it's not within their budget amount, if that makes sense.
Perfect. Yeah, thanks, Emily. All right, the next question, which is an interesting question, I'm skipping around a little bit, I apologize for that, but jumping to those as I see them come in. Any evaluation differences being looked at the varying models of this work? So programs where they have a primary versus secondary response, those who have an EMS responding versus law enforcement. And we've thought quite a bit about that as far as comparing results or identifying what makes sense there. And Katie, I'm wondering if you would like to answer that question and some of the things that we've talked about as far as comparing different models internally to Colorado and the different approaches and what that might look like and maybe some challenges associated with that.
Totally. I think we touched on this a little bit earlier, but the primary and the secondary models, as opposed to models where there is an EMS responder, we're just beginning to kind of scratch the surface of the differences between all of these models. The reason we started collecting this information with the new reporting tool that Jalen mentioned in this evaluation. So what would be ideal is if we could get a really good baseline for this data that we're receiving, and then do an analysis and compare the different program types, the model types of response, and the outcomes for those different calls where different models responded. Like I said, we're just starting to kind of scratch the surface of that with this new data that we've collected. And so it's a bit of a waiting period to really just get a good couple of years of data that will allow us to see a more complete picture of that when we run an analysis.
Okay, thanks, Katie. And Lindsay, I see you typing an answer to the question. I'm wondering if you want to respond verbally as well about, is the 30% data for people who've been enrolled in behavioral health services determined by looking at unique client contacts?
Yeah, I realized while I was typing that it was a long answer, so I feel like this was probably better. Yeah, that's a great question. So this analysis is actually, the denominator is all contacts. So this will include any individual that is served by the program. And we kind of do that because I think one of two reasons, because we don't necessarily know all the information about what's going on in the behavioral health sphere after, they are enrolled or what have you in that specific component. But, maybe it's like each time this person comes into contact with co-responders, this could be a new enrollment, which at least is getting people connected into the services that are provided in their communities. But I think moving forward, what we're going to be able to do with the tool is now we're going to have a little bit more information about if that individual is already enrolled in behavioral health services. So we can kind of see these high utilizers over time to see, how many times is it a new enrollment? How many times is it tracked that they are currently already enrolled in services? So I think that'll be a way that we can kind of understand and tease that out a little bit more for unique individuals.
Great, thanks, Lindsay. The next question is, when do these different programs meet to discuss data collection disparities, review definitions, make sure people are on the same page, etc.? Emily, I'm wondering if you'd like to answer that one as the manager of the programs, and let us know how they work with each other, how we've shared evaluation information, and how they work together as disparate co-responder programs to collectively grow and advance their efforts.
Yeah, so a few different ways. Initially, when we rolled out the new and improved data collection tool, Katie and I had a number of different meetings with programs to talk through it, to talk through concerns, to get feedback and information from them to make sure that we were being as collaborative as possible in trying to develop this, and even were able to make some tweaks and changes based on feedback and based on end user information. We also, there's a co-responder managers meeting that we have every other month where Katie will generally provide a little snippet about data, and programs can bring data questions and kind of talk through some of these pieces. And then the other pieces, I meet with each of the programs every month. And so that is also an avenue where general questions from a specific program around definitions or how we're collecting what they need to do on their end, those also come up during those meetings.
Yeah, thanks, Emily. All right, I think we have time for one more question. Let's see. Someone asked if we could talk about what we've observed or analyzed as it relates to race and or socioeconomic status, specifically thinking about folks being referred to behavioral health services. Katie, I'm wondering if you want to share anything about our race and ethnicity data. We did not collect socioeconomic status information, so we unfortunately can't speak to that, but anything that you'd share as far as our data collection relating to race and ethnicity.
Sure. Yeah, CHI did a really great breakdown of folks on that slide that Lindsay presented earlier, of folks that were able to access behavioral health services, broken out by race. So thank you guys for that. We do collect race and Hispanic ethnicity to align with federal reporting requirements. Typically, the state collects, both race and Hispanic ethnicity in all of our measures for reporting services. I was going to look at the question again, but it disappeared. But we do collect that information. We do not currently collect socioeconomic status information. One of the reasons, like we've mentioned throughout the presentation, I think that we want to keep the burden of reporting low for the programs that are reporting to us. And one of those reasons is because the situation that they're in, the person is in a behavioral health crisis. And so when we start asking a lot of questions about their identity, there isn't that rapport there with the clinician yet at that point in time, and the person may need some de-escalation, a behavioral health assessment that determines whether they need to be entered into the hospital. And so while we would love to collect a lot of demographic data and be able to compare a lot of those things, currently it's challenging to do that. because of the situation on scene and the limited time that the co-responder is able to spend with that person, they want to provide them the assessment needed or the resources that are available to them at the time. But not saying that we're totally throwing that out for evaluation opportunities in the future.
Yeah, Katie. All right, well, we are running up into 9 o'clock. So thank you everyone for joining us. I think we answered almost all of the questions. There's a few that we missed that we will try to answer quickly in the chat, or feel free to reach out to Emily again with additional questions. We appreciate you joining us today. The recording will be live on our website later if you want to look back at anything, and the report link is in the chat. And we're also finalizing our topic for next month's Egghead. So watch your email for that to come in. And for those of you who are avid followers and missed our breakfast puns that I was not able to come up with, we are working on prepping those in addition to the topic for next month. So if you missed out on those, come back in September to get your fix of Egghead puns. All right, well, thanks everyone for joining us. Have a great Wednesday. For those of you with kiddos in school, best of luck on your first week back, and we look forward to seeing you in September.